Hi, I want to talk to you today about my series of talks on ovarian reserve tests, and I want to focus on the FSH, both baseline or basal testing and stimulated or CCT Clomid challenge test. One of the first studies to show the relationship between FSH levels and outcomes was this IVF study published in 1991 by the Jones Institute, which was the first IVF center in the U.S. And what you see here is that as FSH levels go up, fertility rates drop, in fact, really down to zero if the FSH is high enough. Let me point out that this assay they used way back then is a little different than ours today, and our numbers tend to be much lower than these numbers, so please don't use these numbers to compare with what you might get in your blood test today. This is, I think, a really valuable study done by Dr. Scott, who's one of the experts in this field and was also an author on that previous study. What Dr. Scott shows is using IVF, which is a good method to study fertility because we know there was an embryo that went in the uterus at the right time. There were a lot of cycles, so the data points are valuable statistically. We're looking at delivery rates, and I want to point out several things on this study. First, as FSH goes up, fertility goes down. This is, by the way, the scale most people use today. Number two, low FSH does not mean the same thing when you're 40 versus 30. And a high FSH does not mean the same when you're 40 versus 30. So a younger age always translates into better outcomes, even for the same FSH value. So we always have to look at FSH in relationship to age. But the most important aspect of this study is to show that if you look at high enough FSH levels, you'll find a no-go zone. In other words, these people are not likely to make a baby, and they need to know that their chances of success are probably less than 1%. Now, you're going to find some people who get lucky, but not very many. The reason this study is so important is when you read about FSH, often what studies do is they take a value of 10 to 12, which are common cutoffs, and they say, okay, you have an abnormal FSH because it's 14. But look, you still have a pretty good chance of getting pregnant. Therefore, the FSH value doesn't help when it comes to treating infertility. The mistake they're making in that case is they're not looking at the right cutoff. In this study, the right cutoff would be about 19, because then people don't make babies. And if your value is above 19, then you're not going to make a baby, except extremely rarely. If your value is below 18, then you just might get pregnant. That number will vary based on your age and how high the level is. And so that is, I think, a very critical aspect of understanding FSH. Another way to test FSH, instead of just drawing a blood sample at the beginning of the cycle, which is common, is to do a stimulation test. We use Clomid, which works by fooling the brain into secreting more FSH. The ovary responds and makes hormones, which brings the level back to normal. However, if you have a normal baseline, you stimulate the level and it cannot come back, then you have a problem. And that's where the stimulation test can be helpful, is to identify these people who are normal here but abnormal after stress. A common hormone stress test is for diabetes. And we do that in virtually every pregnant woman, and it works the same way. We get a blood sugar, you drink a soda pop to bring your blood glucose level up, and then we see if you have insulin to bring your glucose level down to normal. If you don't, you have diabetes. Same concept here. Now, why do I think this is important? Because when I look at my patients who have an abnormal FSH, 37% only have an FSH level that's abnormal on day 10 after a CCT. In other words, if we had done just a baseline FSH level like most practices do, then we would have been wrong. All right? Now, what does it mean to have an abnormal level on day 10, you might ask? Is it a significant problem? Yes, it can be. Now, 70% of the FSH levels, we might argue, are relatively modest in their increase. But 30% have very high levels of FSH. So in other words, thinking about the Dr. Scott study, we find that 17% of people who have a normal day 3 but an abnormal day 10 are going to have levels so high that they probably are not even going to get pregnant. That would be important to know. And another 14% have high levels that in most labs would also suggest a significant decrease in success rate. And patients need to know what they're getting into. They need to set expectations. It also helps us physicians provide the correct stimulation to get the best outcome. Now, if we look at everyone in my practice who did a CCT, then if you're less than 35, only 6% of my patients had any value that was over 21. That number goes up with age, as you might expect. So the incidence of a really abnormal FSH is really quite low until you get into your late 30s. Now, let's take that same data and now show you that it means something. So as we look at my patients and we look at the increase in FSH level, we see a decrease in delivery rates. The magnitude of the decrease varies by age group, such that by the time you're into your 40s, almost any elevation of FSH is fairly significant with respect to your chance of a delivery. There are a few people who will do a IVF with a high FSH level, and a few of those will get pregnant, but these percentages are somewhat misleading because there are very few cycles there. Here was a study published in 2003 that looked at the issue of the day 10 FSH on a CCT. They found that an abnormal day 10 FSH was just as predictive as a day 3 value. In fact, if we look at their data, if all the FSHs were normal, then there was a 46% pregnancy rate, but it dropped to 25 to 27% when either day 3 or day 10 were abnormal. Now, compared to the entire group, if both FSH values were normal, the pregnancy rate went up 263%. And if either FSH level was decreased, then it dropped by about 50 to 55%. For some reason, if your day 3 only was abnormal, it wasn't quite as bad, but it's still a significant drop. I cannot tell from their study what percent of patients had abnormal day 10 only. I can tell you from their data that 18% of the cycles, the IVF cycles, and some patients did multiple cycles, but 18% of cycles had only a day 10 FSH that was abnormal. So even in this study, the CCT identified a fairly significant number of patients who otherwise would not have realized they had a problem. And again, I think that's important reason for doing a CCT. Let me point out a couple of other quick facts about FSH. FSH reference values will vary between labs, so you have to have your FSH measured in the same lab in order to compare those values. Every IVF center has to establish its own normal and abnormal range because many IVF centers have different success rates. So that's really important. Also, the highest value predicts your outcome, even when their other values are normal. So if you have a FSH of 15 and next month you have a normal FSH, that doesn't mean that your fertility improved. You're still going to act like your FSH is 15. And so measuring your FSH over and over again and then hoping to do a treatment cycle in a month when FSH is normal is of absolutely no value. In fact, it's just delaying your problem. You should get on with it. No test is perfect, so just because you hear about somebody who won the reproductive lottery and got a baby with a high FSH value doesn't mean that that everybody with a high value is going to get a baby. In fact, they rarely are, and that's pretty well established now. Unfortunately, many professionals disagree on how to measure and how to interpret FSH, and so to some degree what tests you have done and why they're done and how they're interpreted will depend on who you talk to, which makes everything kind of confusing. I've tried to tell you how and why I use FSH values the way I do so that you can compare my thoughts to what others might tell you. And I'll end then by saying we do have consensus in our field that FSH is still a valuable test. The controversy is how to measure baseline versus stimulated values and how to interpret what cutoff value do you use and what does that mean. Anyway, I hope this quick review is helpful. Thanks a lot.